Good evening. I am Dr. Yolanda Lawson, the 124th President of the National Medical Association. I would like to welcome members of the National Medical Association and other guests in joining us tonight in this vital webinar titled COVID? Yep, it's still here. Everything you need to know. As we navigate the ever evolving landscape of the COVID 19 pandemic, the statistics and realities presented by the Kaiser Family Foundation are stark reminders of the challenges we continue to face. The intention to get vaccinated is clear among nearly half of US adults. Yet, as of October 14, 2023, just 7% have received the newly recommended COVID 19 vaccination. Tonight, we come together not only to acknowledge these gaps, but to bridge them with knowledge, understanding, and a shared commitment to the health and well being of our communities. I'd like to acknowledge the collaboration and partnership with BlackDoctors.org and Novavax in helping us, in supporting us, and bringing this content and this webinar to you. We recognize the need for ongoing education and resources remains paramount. In the past week, ending October 28, 2023, over 15,000 new hospital admissions and nearly 600 deaths per week were reported in the United States. COVID-19 persists as a formidable public health risk and a leading cause of death. It is within this context that our esteemed panel joins us tonight and when we'll provide you with insights, strategies, and discussions that will empower you in the face of this continuing challenge. The purpose of our webinar is clear: to equip you with the tools to stay healthy and safe, especially as we approach the holiday season. Our distinguished faculty, including Dr. Hewlett, Dr. Kane, and Dr. Bennett, bring a wealth of expertise to this discussion. So let us engage you in this conversation with open minds, ask questions, and actively participate. Together, we can work towards a healthier and safer future for all. Without further delay, I'll turn over to Dr. Hewlett. Thank you.
Thank you so much, Dr. Lawson, and good evening to all of you. It's indeed a pleasure and an honor to be able to join with you and to moderate this important session for the National Medical Association. And as Dr. Lawson indicated, this important partnership that we have with BlackDoctors.org and Novavax. And so tonight I have the distinct pleasure of introducing two panelists. First and foremost, I'll introduce myself. I'm Dio Hewlett, and I am a medical director with the Westchester County Department of Health in Westchester County, New York, and I'm also an adjunct associate professor with New York Medical College. I want to introduce my longtime friend and colleague, Dr. Virginia Kane, who is Director and Chief Medical Officer of the Department of Health in Indianapolis, Indiana, the Marion County Department of Health. She is also an associate professor with Indiana University School of Medicine. And importantly, she is the president-elect of our National Medical Association. In addition, our other panelist will be Dr. Chijioke Bennett, who is a senior director of clinical development with the responsibility for leading clinical development programs for the COVID variant vaccines and the COVID vaccines in immunocompromised populations. This is going to be a very important discussion for us because we have been challenged by what we need to do for our immunocompromised patients. And we know that these are the individuals who are most vulnerable in our population. And so I will turn this over first to Dr. Kane, and then following that, we will have an open discussion about some very important topics. So Dr. Kane, take it away.
Well, thank you, Dal. I appreciate it. If I could have the first slide. And when I'm just going to first say that I have no financial disclosures. And I want to talk about that since the United States passed the 1 million cases, and we actually had 103 million cases back in March of this year. We've also passed 1 million cumulative deaths that have been tied to COVID-19 in the spring. And since that time, approximately, we've had about 152,000 additional people have died in this with this disease. And so COVID is not over. And so we want to just talk about the recent trends that are happening. COVID, have the next slide. This slide just shows two maps of the United States. One showing where we were, those that are highlighted in the yellow, how just this recent in March of this year, we saw a lot of our cases sort of fade. But if you look at the map, that seems like you see all of those highly red dots. That's highlighting the deaths that occurred last year around this time. And you can see the major difference between the 2 years of this map from the New York Times. Next slide. And it's so important about this COVID epidemics that when we look at the epidemiology and who it's impacting, we see that people of color are more likely to be devastated by this COVID-19 infection. If you look at our Black residents and our Hispanic residents, we had about 2.5 times the rate of hospitalizations compared to our white residents. And with the Native American, actually almost 3.2 times compared to the white residents. But also, it resulted in a greater number of deaths, almost nearly 1.7 to 1.5 the number of deaths if you were Black or Latino, but over 2 times the death rate if you were Native American or Alaska Native. And so it just highlights how important this infection has been, hitting our vulnerable, underserved populations who may not always have access to health care. Next slide. This map just shows what the epidemic looked like. So as you can see, we saw our first peak around in just after September in 1920. And then we saw our biggest peak of hospital admissions in December of 2021. And then as a result of us implementing a lot of procedures, such as vaccinating individuals, wearing our masks, doing social distancing, we saw a significant decline in the number of COVID cases in August of 2022. And then we're now seeing just this year in 2023, November, still continuing to see a smaller bump. But you have to remember, those months of December and January are our most critical months where we see the highest rates of acute respiratory illnesses, especially in the winter months. Next slide. So this just looks at, if you wanted to see where we are with new COVID-19 hospital admissions rates per 100,000 population, those states that are in the green continues to show we have a low transmission right at this particular time of COVID-19. And as you make it into the yellow parts of the counties, you will see that the transmission rate is moderate. And then when we hit those orange counties, that's where we're starting to see higher rates of transmission of COVID-19, for example, like in South Dakota and other places of that nature. Next slide. Now, this is really critical because we're also seeing not only an increase in COVID-19 cases, and if you can look at this map, it's the very top line that's orange at the very top. And as you can see, it is sort of since last October 2022, it's sort of been flat plateau, but then we saw a little bump in September and now it's slightly on the decline. But I do want to tell you, look at that blue map, and you can see how we saw a significant increase of influenza. And we actually just had our first death from a pediatric influenza case coming from Mississippi this past 30 days. So you can see that we're experiencing a lot of acute respiratory diseases. And just in November, we're starting to see the increase with not only influenza, but the RSV virus that we commonly see in a lot of children up to 8 years of age is now being transmitted to adults. So we're seeing an increase in our influenza cases, our RSV cases, and we're sort of just been a little bit lower. We're down from last week with our COVID-19 cases. We had 1,400 deaths in September. Now, this is well below compared to last year when we had 26,000 deaths with COVID-19, but we still have to wait to see what's going to happen for all of us in January and most of February. Next slide. This slide just highlights the emergency department visits. And as you can see with this slide, we're still seeing an increase of influenza cases that are carrying. Our COVID-19 cases in our emergency rooms is sort of plateauing and declining just a little bit, but definitely an increase in our RSV virus that is taking place just in November. Next slide. This is an important slide because when we look at COVID-19, who's the one that's most likely to be impacted? You know, who's diagnosed and who's got the most serious infection? Well, believe it or not, that top line is lavender. It's my favorite color. And we will see that still individuals who are 65 years and older are the ones who are the heaviest hit by this COVID-19 infection, and is followed by our 64 to 75-year-olds. So if you're over 75, they're the greatest number of COVID cases we're seeing, 64 to 74. That's the next group. And the group that we're seeing with the lowest number of cases are our younger children, 12 to 15, and our 18 to 24-year-olds. But still, a tremendous number of COVID-19 cases. And one of my colleagues that's infectious diseases, along with Dal and I, who's actually in Ohio, is stating that they are now in one of their hospitals have as many as 25 patients now admitted for COVID-19 that they didn't see 2 weeks ago. So we're just about now starting to see the increase in our COVID-19 cases. And listen, folks, Thanksgiving is just around the corner. People travel, have their relatives come from all over the place, and we see these large gatherings of people for Thanksgiving. So I just want to say, please, you know, if you've got any symptoms, like you've got a cold, runny nose, shortness of breath, or coughing, try to eat your turkey at home if that's possible. Next slide. This is saying that one of the issues that we faced in our communities of color was our low vaccination rates in the African American populations. And we saw that we had the lowest vaccination rates compared to our Latinos, and especially our white residents. And so we do have our work cut out for us, but of those who have received the primary series, 46% of African Americans had received a COVID-19 vaccination, compared to our Latino community at a little bit higher percentage. With our white population, nearly almost 70% were vaccinated. So we find out that for those who are vaccinated or you're unvaccinated, you have 8 times the risk of being hospitalized, but even more important than that, ending up in the intensive care unit utilizing a respirator. So it's just so important that we really encourage vaccinations related against COVID-19 as well as the flu. Next slide. This is a study that was done by Kaiser, and they did a focus group. And I think this is important to say that when we looked at this focus group and to determine who's already got their COVID-19 vaccination, believe it or not, between Black, Latinos, and whites, African Americans at 26% had already gotten their COVID-19 vaccine, with about 13% saying that they were definitely going to get it. So almost 59% of Blacks saying that they are going to get their COVID-19 vaccine, followed by the Hispanic population with about 20% who had already received the updated COVID-19 vaccine, with 14% saying that they were definitely going to get it. But even look at, compared to our white patients, only 19% have gotten the updated COVID-19 vaccine, with only 13% saying that they're definitely going to get it. So as you can see, we are doing a much improved job of really encouraging immunizations in our racial and ethnic populations in this country. Next slide. So, why? What's the rationale? What are some of the things we should consider why we should get vaccinated? Well, I want to talk to you about the long COVID, those post-op conditions related to COVID. We know that many people recover after the acute phase of their infection, and they may take days, it may take weeks, and we have a significant number of people who never get any symptoms, but they are contagious by just talking, spreading respiratory droplets within the air. And so we now know that there have been a lingering of symptoms for a number of folks who had this acute COVID-19. And they've self-reported the presence of these symptoms for at least occurring 3 months after having COVID-19. And it's unfortunate these symptoms can be mild. They can have severe COVID-19, which can lead to long COVID. And these symptoms are lasting weeks, months, or even years after the initial diagnosis. But a major point that 1 in 4 adults are saying that those who experience long COVID, 1 in 4 experience a significant decrease in their physical activity. Next slide. What are some of the symptoms of long COVID? The number one factor that we hear a lot is patients are experiencing a chronic fatigue syndrome. They're just tired. They're exhausted. They don't even have, a lot of times, a couple of good hours during the day. They're that exhausted that a significant percentage of them lose their jobs. They may be impacted by shortness of breath. This COVID-19 impacts the organs. They may have chronic cough. They may now experience new joint symptoms like arthritis. They can also experience some cardiac symptoms, such as they may start to get chronic heart palpitations, or they may have chronic chest pain. And some of them are at higher risk for strokes or seizures. Next slide. But I think the thing that's also very bothersome is when patients are complaining of they've got this brain fog, their memory, they can't concentrate. They can go and buy something at a store and they can't calculate what their change should be. And they just can't multitask like they used to. And some of them experience sleep disorders, but they can develop rashes, hair loss, A lot of them experience some post-traumatic stress syndrome, anxiety, depression, but they may also have chronic pain or chronic headaches, as well as the classical symptoms we see, a loss of smell or taste that can last for weeks. Next slide. So, what are the recommendations for this new COVID-19 booster vaccine? Next slide. CDC and ACIP, these are these experts that make the recommendations, now have 3 special vaccines that they recommend out there for people who are not moderately or severely immunocompromised. So that if and the beauty of it is we now are able to give these flu shots annually, just like the flu shot. So one of the vaccines that is using the technology, developing a protein-based vaccine that we normally have been used with most of our flu vaccines, where now is called Novavax, that is able to be given to someone if they've had a prior vaccination before. Then all they require is just one Novavax dose. But if they've never been vaccinated before, then our recommendation is that they get 2 doses of Novavax. But we also know that there's this new messenger RNA technology that we've utilized, and we have 2 other vaccines called Moderna and Pfizer that can be utilized. And so if you've been, you can get 1 dose of either one of those vaccines, Moderna or Pfizer. And the same as if you might have even had 1 dose prior of an updated COVID-19 booster before in the past. And if that's the case, if you've been vaccinated already in the past 6 months, then you can either use 1 dose of Moderna or 1 dose of Novavax or 1 dose of Pfizer. And we are recommending that people can start getting vaccinated at 6 months and older based on the vaccines that are utilized. But Novavax is recommended if you're 12 years and older. So next slide. Also know that sometimes you may require additional doses if you are moderately or severely immunocompromised. And so sometimes if you've already been vaccinated and you've received your primary series of the COVID-19 vaccines, then you may be able to just get 1 dose of Moderna, 2 doses of Moderna if you've been vaccinated, because this is a special vaccine. It is covering the new variant of the Omicron strain of this COVID-19 vaccine. And we have to update our vaccines because these viruses mutate all the time and they change a lot. So if you've never been vaccinated, but you are moderately or severely immunocompromised, and I'm going to talk about those conditions that you can use, considering that you may require 3 doses of Moderna, you may require 3 doses of Pfizer, but you would require 2 doses of the Novavax, extended over a period of weeks. And just my last slide next to this, after this, people who we consider moderate and severely immunocompromised are patients who are like cancer patients and they're on chemotherapy. Or you may have a rheumatoid arthritis and you're on a sort of a immunocompromised therapy, such like prednisone, taking 20 milligrams or greater. Or you may also be an organ transplant patient and on immunosuppressive therapy like a kidney transplant patient, or have advanced HIV infection where your CD4 count, we sort of measure your immune status. And if your CD4 count is less than 200 cells, that tells us you're at high risk for getting an opportunistic life-threatening HIV infection. And so these are the ones who may require additional doses if you're moderately and severely immunocompromised. But remember now, people, as you get older, you may have different medical conditions that put you at risk. And so please consider to safeguard yourself, get these COVID-19 vaccines. And if you are pregnant, it's recommended that you get a COVID-19 vaccine, because otherwise the actual COVID-19 infection can cause a pregnant mother to have a preterm baby and higher risk for complications. So thank you, appreciate you, and I'll wait to listen to any further questions. Thank you.
Thank you so much, Dr. Kane. We always learn so much from your discussions, and it's certainly great to have you on this program today. And I want to start with some of the questions that we are going to be receiving, but actually I want to put in a few questions of my own, because you raised some issues, and I'm going to put Dr. Bennett on the spot here because of his role as in the clinical development program for Novavax. He can answer a few questions for us. And one of the questions that I have is we know that immunocompromised patients, this is a heterogeneous group. So one of the questions that we have is, what are some of the population groups that you have actually studied or that have been studied? And one of the other questions that was raised, that I think is raised by what Dr. Kane said, is how well is this vaccine tolerated compared to our mRNA vaccines?
So that's a really good question. Thank you, Dr. Hewitt. We've done work with the HIV community, and we've sort of split them across two categories. We have what's called the well-controlled, those who have higher than 200 counts per milliliter for their CD4 count, who are on HART therapy, who don't have any infections that are opportunistic, those sort of participants. And we have those who have a bit worse indices when it comes to their immune status. And what we've noticed is consistent with what Dr. Kane had presented, is that these population groups have to be dosed differently than what we give to the general population. And we have toyed with a few ideas. Do we give them more doses? Do we give them longer intervals? And the data suggests that these people need to have more frequent dosing to help them mount the same immune response as the non-immunocompromised participants in the community would have. But what becomes really interesting is that you sort of get this best mix when they've had prior infection and a vaccine. I know people sort of ask the question, hey, I had a couple of months ago, should I still get the vaccine? And the answer is an emphatic yes, you should get the vaccine. Because number one, as Dr. Kane did mention, these viruses tend to drift, they tend to shift. And so if you're relying on what you got in the past to protect you, you might have something quite different in circulation now. So the combination, and we've seen this with our HIV participants, if you're able to combine a baseline infective status done by the anti-MP protein assays, so they've been exposed to the disease as a natural infection, and you dose them on top of it, actually miraculously eliminate the disparity you find if they haven't had infections in the past. So the trick is we have to treat them differently and find what works best for them. And what works best for them in this moment is more frequent dosing regimens than what happens with the general population. To your second question about the tolerability of the vaccine, it's been really good. And I say this, every vaccine would always have a risk-benefit profile. You really want to make the decision for yourself. Talk to a healthcare provider, talk to somebody who understands your health snapshot. This vaccine, the risk versus the benefits, you do the math. Would you want to deal with maybe a bit of soreness in your arm post-vaccination, a bit of a headache, or do you want to end up in the ICU? So, I mean, it's really been well tolerated. There have been no concerns across both vaccine platforms when it comes to the benefit of both platforms. But I think it's really important that we drive home the point that you might have some discomfort for some length of days, that we want to assure that the benefits far outweigh the risks of getting the vaccines.
Thank you, Dr. Bennett. one question that came up that's along those same lines of tolerability, and I'll ask you and Dr. Kane to comment on this, and I know we've had questions about this at our health department as well, is the rates of tinnitus following the vaccine. Is that something that has been a major problem, or is it something that is only seen occasionally?
Dr. Kane, do you want to go first?
So I do know that we have had some reports of some cases of tinnitus associated with the COVID-19 vaccines, and that's been just more recent data that we've identified this year. So it's not a frequent or a common occurrence. The other thing is that you can have tinnitus and a hearing loss also just with the COVID-19. What happens is that this virus gets into your body and it starts replicating, and it replicates in what we call the cochlear nerve that's inside your ear. And as it multiplies, sometimes it can cause some damage. You may have some balance problems, but you can also be associated with hearing loss and ringing in the ear as well.
Yeah. And I think that's a really great point that Dr. Kane makes. One of the big concerns we have is how do you make the distinction between the vaccine and the virus? Like what is happening, what's causing what? I think one of the key things I want to assure the public is this. For every vaccine manufacturer, when we do get safety concerns and we think it's a signal, there's a very robust, rigorous method to look through all the data to see, hey, are we seeing this happen a lot more? Should we pay attention to this? And the FDA is also looking at this data as well. So yes, we have seen instances of tinnitus in participants who got the vaccines, but it hasn't risen to the point again to the question about risk benefit analysis. It's not a concern that will cause us to pause vaccinations. We do understand it's extremely uncomfortable. We understand it's not the best way anybody wants to spend their days having ringing in your ears incessantly. But I think it's important we make that note to the public. We are ignoring this safety data. We're looking through it, combing through it. If anything rises to the point of being a signal, it's thoroughly investigated. And if that's the case, those signals get slapped on the package insert. So your physician can tell you, oh, by the way, this might cause this. So whatever you see in your package insert, and having a conversation with your healthcare provider is what has been rigorously distilled from data across multiple participants.
Thank you. One big question that comes up, and this is a question that we have every year, and that is, even before COVID, we were facing influenza. Every single year, influenza comes to town, and it actually takes people away, and we can prevent influenza. And the question that comes up is that, can we receive both the COVID and the influenza vaccines at the same time? And do we expect to get the same level of protection if we receive both of the vaccines together? And in fact, I just had someone ask me last week, can they also get the RSV vaccine along with the COVID and the influenza vaccine? So the question for both of you.
So I just think people are a glutton for punishment. But let me just say, influenza, we got to remember, that's a serious infection. And we know that annually, anywhere between 12 to 52,000 deaths can occur in a year on the average of about 36,000. But the answer is yes. You can get the COVID-19 vaccine and the influenza vaccine at the same time. I preferably think you should use it in different arms and not have it in the same arm, but I'm told that some people can even have it in the same arm. Now, when you combine, you may have more of a reaction, local reaction, because you're taking both at the same time, but that is quite possible. Now, can you get the RSV as well? Well, the RSV is a newer vaccine. So I'm not the risk taker like some of my colleagues are. So I would probably say I wouldn't get all three at the same time, but you can get I'd wait at least a week before getting the third vaccine, RSV, but both COVID, influenza. But let me just say, I've gotten both my COVID-19 vaccine, and I just had just a little, it all depends too on who's giving you that shot. But I also had just very little pain, discomfort that lasts maybe for me, it was just 30 minutes or whatever. And I didn't have any problems. And I got that on moving and working like nobody's business. And the same for me with my influenza vaccine that I just waited a couple of days, but you can't get both.
Yeah, I can probably just add to Kate said. I will tell you a personal story. I got my wife last year to get the flu shot and the COVID shot the same day. And boy, did she hate me for it, because the reactor was insane. She was like, "What have you done? You should know this stuff. Why would you?" I'm like, "Listen, it was just convenient. We're here. We're right here in the pharmacy. Get both." So again, yes, you can. But to Dr. Kane's point, you might just be a lover of pain. It might knock you out, but there is no concern about the synergy. You are not going to have any one weaken the other. They would independently and function effectively. And again, maybe give yourself some time to not get run over by a Mack truck, getting 3 vaccines at once. But hey, if that's what works for you, then make it happen. We prefer that you get it rather than you don't get it.
Now, one thing I do want to caution people, because they think that once I get that vaccine, I'm immediately protected. So this vaccine produces some substances in the body. It's not the real live virus, okay? Mm-hmm. But it's a substance that your body thinks is foreign, so your body starts to build antibodies. And that normally takes about 2 weeks. So know that you're not protected for about 2 weeks after you get your immunizations.
And can I just add one extra note of caution to what Dr. Kane said? The vaccines are not supposed to prevent you from getting the disease, period. Their task is to prevent severe disease, being hospitalized, or possibly dying. So the fact you got in the vaccine and it doesn't mean you still won't get the disease. You'll just probably be safer in terms of death or being severely ill.
It makes you have a milder infection. It cuts substantially down on hospitalizations. But even more important than that, you don't want to be in that intensive care unit on that respirator for weeks, months. You don't want that to happen. So
we don't want that.
Get your milder version of infection.
One big question I have I'll ask Dr. Bennett first, and then of course Dr. Kane. I think I know what Dr. Kane is going to say, but a lot of people might be concerned about the new vaccine, the Novavax vaccine, and use in pregnancy. And I wonder if you can comment on that. And then also the experience we know that with the mRNA vaccines, we were vaccinating children as young as 6 months. What is the data and recommendations on the use of the Novavax product?
I'll let Dr. Bennett talk. Go on, Dr. Bennett.
Thank you, Dr. Kane. Thank you, Dr. Helmet. So our vaccine has had no issues in pregnancy at all. We have real life data being collected at the moment, sort of get more numbers into that database, sort of see how the vaccine performs in pregnancy. But I think to also echo what Dr. Kane said initially, if you're pregnant, please get the vaccine. Yes, pregnant women can take Novavax vaccine. It's safe in pregnancy, no concerns. But actually, I have a funny story for you. When we ran our studies in South Africa, you know how you're doing a study, say people should not get pregnant in the study. We had a really high pregnancy rate, and I joked and said, perhaps we've made a fertility vaccine as well. And there were no concerns with anybody getting the vaccine. The vaccine has proven to be safe and efficacious in pregnancy, and also helps mother and the unborn child. I think it's really important that we make the point. And data is being collected in real time by our colleagues in the real world evidence circle to pull in data and sort of present that data at a later time point. But thus far, there are no concerns in pregnancy. Recommendations at this point are vaccines recommended for participants. I keep saying participants, patients who are 12 years and older. That is the authorization we have in the USA. So if you're 12 and older, you're eligible to get the protein-based vaccine as produced by Novavax.
Okay, thank you. we have one question, which is a public health question, which I'll direct to Dr. Kane, having to do with masks. And what is the current recommendation as far as masking is concerned? We know that this is a hot topic around the country.
I don't see
Dr.
Dr.
Kane,
Kane.
what happened? Well, maybe I can answer that. I know that in our healthcare facilities, we are still wearing masks when we are rendering patient care because we feel that that's the safest thing for us to do. Now, of course, we don't really have control outside of our healthcare, our healthcare facility, but that's actually what we're doing in the healthcare facility. We're recommending that people. The question, Dr. Kane, is what is the current position and recommendation on masking? And
So
I was going to ask you that.
Yeah, so I would say that if you're an individual that has a chronic medical condition, let's just say you have congestive heart failure, you have asthma, chronic renal failure, or a liver condition, I think that when you go out into large crowds, you should be wearing a mask. Okay, I really think that you're at a higher risk for more severe complications. So wear that mask, especially if you're in large crowds or you're in enclosed. Let's just say, hey, I'm catching a bus to go visit my friends, or I'm catching a plane. Wear that mask, especially in enclosed spaces. And listen, hey, if anyone is sick, like if you got a runny nose or a cough or anything like that, it is so important for you to wear that mask so you don't spread those contagious respiratory droplets to anybody else that may be in that household. Let me tell you, someone sneezing, that's almost like 1,000 respiratory droplets. It will remain in the air even after you leave that particular space. It will remain in the air for 30 minutes or more, even longer. And don't forget, you can be touching different surfaces. So, those doorknobs when you go into your house, any of those frequent, you hit that refrigerator door maybe more than you should or whatever. Make sure you consider wearing masks. In sanitation is important. Wipe down things on a frequent basis. Wash your hands. Publicly, you don't have the ability to wash your hands with soap and water, get a sanitizer, hand sanitizers, but they have to have at least 50% of alcohol in it or greater.
Mm-hmm. Now, Dr. Bennett, we have these new vaccines out and we have all the publicity about these vaccines since the month of September. And the question that comes up now is, well, how long do you think that this protection is going to last us before we have new variants that come out and we have to then go back and get vaccinated again? And the other question is, do you think that technology will get to the point where you can put all of these vaccines in the same syringe?
Ooh, that's a loaded question. So viruses will do what viruses do. They will always drift. Part of what we aim to do with our vaccine offerings in the fall is find a variant or a strain that is closely related towards a circulation. Now, at the point the FDA and the CDC made the recommendations for what we have in syringes now, which is the XBB.1.5, that was what I call the flavor of the month. That flavor has since changed, but the change is still what we call phylogenetically related. So even though it's a different name, it's pretty similar to what is in the syringes as well. So what you're getting is sort of, think of it as a first cousin of what is in circulation at the moment. So what you get in your vaccine shots helps protect from is in circulation now to the best way possible. Now the big question is what happens in the next 6, 7, 8, 9 months. The truth is, from the data we've seen in the vaccines, and this is sort of across both platforms, the correlate of protection have always been the neutralization antibodies. Those numbers begin to drop around the 4 to 6 month period. that, and I think that's in a purely perfect world. With the combination of infection, you also had that sort of benefit of having both the vaccine and the ongoing infection. So in a way, you're doubly protected. But would we get an updated vaccine in the future? Yes, we'll have to. The point is, what will that new vaccine look like? And to the wonderful notion you said of combine everything in one shot, I know there were talks to have a pan-coronavirus vaccine sometime in the future. But I think what becomes important, and this maybe is how to tweak the antigen so no one antigen overpowers the other one, and you have a more synergistic vaccine than you would have if you just threw everything together. We'll have to sort of get into the cadence of flu for a little while as we figure this whole thing out. We'll have to do that flu dance. Mm-hmm. The frequency I can't predict now. Would it be semi-annual? Would it be annual? But at some point, I have to think of COVID as one of those things we get on a predetermined fixed basis as a vaccine, and sort of walk our way into more vaccine research in the future.
Well, I'm more optimistic. Oh my goodness. Okay. So who would have thought, hey, a couple of years ago, for our HIV patients, you can have 3 medications all in one pill. Who would have thought that? Okay. So I think it's quite possible that we're going to have a flu vaccine combined with a COVID-19 vaccine. Guys, I don't know how your industry work it out, but y'all can work it out. And I think we're going to have a combination vaccine. So all I got to do is get one shot, okay? And I got my flu and my COVID-19 together.
So I can tell you now, Dr. Kane, that we are working on a flu COVID combo vaccine at the moment.
See, what did I say? See, the miracle's already trying to happen now, okay?
You point out, and I think every other vaccine maker is doing the same thing as well. And you're right. It's the ease, it's the convenience to give you the one shot, the one and done. And actually, there's even talk about a flu COVID RSV vaccine as well as one shot. I think people are trying to get to this notion of whatever makes people take that vaccines have a bit more uptake. If it means on, let's get that shot in your arm. So you're right. We are working our way to a combo vaccine. I think it's going to be a great deal once we can get there.
Now, I have a very important question to ask. First, I'll ask Dr. Kane from the public health standpoint and government policy standpoint, and then I'll ask Dr. Bennett from the industry standpoint, because I know that there are responsibilities. But one of the problems that we're facing right now is access to the vaccines. We know that for vaccines for children, vaccines for adults, for people who are uninsured, they're able to get the vaccines from our health department. We can do that, but we have now been told that unlike last year and the year before, when we could give the vaccine to everyone, we can no longer do that. And we are told that there's this bridging program that people have to enroll in order to get the vaccines. And we know that it feels funny for me as a health department person to tell people that they should be going to the chain pharmacy to get their vaccines, but that's actually what's happened. So Dr. Kane, what advice can we give people who want to get the vaccine, but then they are insured and there are some obstacles that they have to overcome?
Well, this year's the first year that we've gone commercial in terms of pharmaceutical companies being able to charge for the vaccine. But as you know, because of that Emergency Authorization Act ended in May, we had a number of our residents get laid off of the Medicaid rolls from a number of states. And so, whereas they had insurance, they no longer have insurance. And CDC and HRSA, the Department of Health and Human Services, have developed a bridge access program. So that if you don't have any insurance, we have this wonderful program, Vaccine for Children. So if you don't have any insurance or you're underinsured, you can get free vaccine. We're trying to implement that one for adults. And so they're using a model just like that for children to give to providers who see a lot of homeless clients and see a lot of patients who don't have the money or can't afford to pay for the vaccines where you can go to them and get a free vaccine. You can go to your fairly qualified community health centers and get free vaccines. But we have a number of providers that the State Department of Health contracts with the local health department. And local health departments also provide free vaccines. And, if you're lucky, some places in a large metropolitan city will have mobile immunization units, trucks that will go out into the inner city area in places to provide that vaccine. So, because they can't always have to come to you. We need to go to them to provide those necessary vaccines.
Yes, thank you. A quick question for Dr. Bennett. We have encountered patients from time to time who had actual allergic reactions to the mRNA vaccines, and the specialists have told them that they shouldn't really get that kind of vaccine again. And so, what are the precautions, or what are the protein subunit vaccines alternatives for these patients, and are there any concerns that these patients might have?
Yes. So if you're not able to take one of the mRNA vaccines, you do have options, and you have the recombinant protein-based vaccine that we make, Novavax, as a really good option. I think Dr. Kane made this point. It's a familiar platform. We've done this to many other vaccines in the past. It's more widely known. It's more accepted, and so you do have the option to get that vaccine as well. Like I mentioned about clinical trials, in this industry, you really can't just throw a thing at the public. It has to go through rigorous, and I use the word intentionally, rigorous levels of scrutiny for the data, for the safety, for the efficacy. And so what you see in our vaccine, that for the FDA gave us the authorization we have now in 12 years and older, they review the data, and your concerns, whatever they are catered to, because the one thing that the agency made us do, and made every sort of sponsor do, was have a diverse clinical trial population. So we were proud that we could see people that look like us on this call in our studies as well. So whatever your concerns are, hey, will this work in me? I'm like, yes, it should work in you, barring any other health conditions. But again, I want to make this point. We can't sit here, the three of us as MDs, and prescribe what works for your health situation. Find a person who understands your health, your healthcare provider, your primary care physician, and have that conversation with them. But yes, you do have options now. If you don't want the mRNA vaccines, you can totally get the recombinant protein vaccine that we make in the vaccine.
Great. And I see that we're running up to the last 5 minutes, and so I don't see questions in the question box. However, I'm hoping that maybe we can divide this time between the two of you for parting words, or areas that you feel you'd like to have everyone take home. And so for the next 2 minutes, Dr. Kane, and then the last 2 minutes, Dr. Bennett.
So I think for me is that we have such it's so important that we're seeing these COVID symptoms that can impact even our children. And they can have this special inflammatory syndrome that they can end up being hospitalized. They can be in an intensive care unit. But we also have a significant number of individuals who have no symptoms whatsoever, and they're contagious and it's infectious. So I may tell a young patient who's 18 to 24, hey, I feel good, I'm healthy, I work out, I don't need this vaccine. Well, maybe you don't, but if you ever go around, maybe you have some parents who are older, or grandparents, or aunts, or you may know someone who's may have a high risk condition, you need to take that immunizations to protect your loved ones. If not yourself, think about your loved ones. And hey, get plenty of sleep, eat right. Okay, that's the key to avoiding infections. And also know that there are some treatments out there that if you think you do have a mild version of COVID-19, but you're at high risk for complications, you got about 5 days to get a medication that can ameliorate those symptoms and make them much milder. So, hey, come come talk to a bug doctor, okay, or
Yeah.
an educated healthcare professional who can provide those answers for you.
Thank you. Parting words, Dr. Bennett.
Oh, Dr. Kate had such wonderful parting words. And I guess I just want to talk to my generation. We're younger, we think we're healthier. But please don't fall for the fallacy of youth. This virus respects no age group. It will get to you. And so what Dr. Kane said, it might not be you who suffers the acute disease, but for the sakes of your family, your community, those who don't have the top shelf immune system that you have, get it for them. And please, I just encourage you to have the conversation when we're having our sweet potato pies over Thanksgiving. Have a conversation with your family. Reach out to them. Our numbers for vaccine uptake in our community has not been historically great, and I understand why. But if people who know people talk about vaccines across dinner tables, in the barber shop, at your nail salons, we can ramp this uptake up. So don't be afraid to have the conversation. But my only caveat is don't spread false information. Make sure you know where to go for the right information. Go to vaccine.gov, go talk to your healthcare providers. But let's have the conversation in our communities and don't fall for the fallacy of youth, because COVID is not.
Thank you, Dr. Bennett. And at this time, I do want to thank both of you for just a wonderful discussion here. I think that it has been very stimulating. I hope that the audience will take a lot of these points home with them. I think that this will be available for future use, this particular broadcast. And as Dr. Bennett mentioned, I hope, and Dr. Kane mentioned this also, we hope that you will rely upon your healthcare providers and not fall prey to some of the false things that you hear on the internet. And in fact, we hope that you won't fall prey to some of the things which are so-called misguided political leaders telling you what to do. So at that point, I think I will adjourn this session, and it has been a pleasure and a privilege to work with everyone here. And thank you to Novavax, to blackdoctors.org, and of course to our parent organization, National Medical Association. So we wish you all a good evening. Thank you.